right. Okay, welcome everybody. More folks should trickle in. Actually, let me try moving this over a little. So welcome. We're gonna use this lunch hour to talk about buprenorphine in the era of fentanyl, and I added in a changing drug supply and some updates for new prescribers. So we'll do some stuff that if it's your first time prescribing buprenorphine, hopefully are helpful, and hopefully there's some pearls for folks who are doing this work already. I don't have any relevant disclosures. And so I am one of the consultants for MCSTAP, the Massachusetts Consultation Service for Treatment of Addiction and Pain. This is how you reach us. We support clinicians across the state to really increase your comfort and capacity using evidence-based practices to screen, diagnose, treat, and manage folks with chronic pain and or SUD. So please call us. We're open Monday 9 to 5, and we have a website with other resources. What do? We have real-time coaching, just one-time consults versus longitudinal coaching. We have the ability to connect you to resources in your community and technical support if you are sort of looking for practice-changing help. And here's a list of sort of things that we do, including special populations, etc. The other piece to know is that we have recently, maybe in the last year, started to be able to offer some longitudinal mentorship sessions. So those are really fun. And it's a sort of one-on-one case-based review of areas that you want to grow in. And so it's really, driven by the mentee and a nice opportunity to get some, thoughtfulness around cases that may be challenging for you. Okay, there are a ton of us physician consultants, and we all have expertise in these areas and a really commitment to helping others. So with that, you can get Sammy for this talk and for your, not for your one-on-one calls, but if you do the mentoring. So this is how you do it, and Amy will share that information later if you need it again. And now I'm gonna dive in to my talk. So by the end of today, you should be able to describe the core aspects of prescribing buprenorphine and apply them in practice. We're going to compare available buprenorphine formulations and induction strategies, including some of the strength supporting evidence we have, and then examine how illicitly manufactured fentanyl and other drug adulterants impact buprenorphine management and titration. So I'll start with a case. This is a guy who came in and said, "Doc, I heard about buprenorphine films from a friend. Can you prescribe it to me?" Right? So this is really the first part of just making sure everyone's on the same page of how we evaluate and treat and prescribe. So more information. He's a 56-year-old male, retired laborer, shares he's been taking non-prescribed oxycodone from a friend for years to manage his chronic pain, as he couldn't find someone to prescribe the dose he needs. He's spending hundreds of dollars a week on pills, he tells you, and he prefers OxyContin 30 TID when he can find it, but often can't. And so over the next couple of slides, we're going to talk about some questions. What criteria does he meet for an opioid use disorder? What other history is relevant? Is he a good candidate for buprenorphine naloxone? What do you need to know about prescribing? And then what else should you be thinking about for safety and harm reduction? Sorry, I'm just moving this. A little more history. He shares he's never injected anything and never insufflated, so really using pills. And so how do we make the diagnosis of a substance use disorder? A lot of you are probably familiar with this, but just remember it is a clinical diagnosis requiring at least 2 or more of the following DSM-5 criteria. And those include hazardous use, impact in your social or interpersonal roles, neglecting roles such as jobs, home, relationships, responsibilities, using longer than intended, repeated attempts to quit or control use, spending a lot of time with a substance, craving, physiological or physical problems or psychiatric problems due to the substance use, giving up activities due to use, and then withdrawal intolerance. And so this guy has certainly had increase in tolerance. He is using larger amounts and longer. He is maybe having, impact in terms of psychological or physical problems. We haven't gotten into that. Is getting, non-prescribed potentially medications, which sets him at risk. And then we didn't specifically ask about withdrawal, but he at least meets 2 or 3 of the following criteria. So we would give him, an opioid use disorder diagnosis, and it's very appropriate to treat him with buprenorphine. So the question is, like, why was he buying pills, right? Why do people do this? This is not news to anyone, hopefully, but the stigma of going to your primary care or your provider to ask for opioids, right, or treatment of pain is really pretty significant, as well as the fear that a lot of people still have about asking their providers about buprenorphine. And so as of 2020, only 10% of primary care providers prescribe buprenorphine. And I think you could also look at this as a safety thing, right? He's trying to potentially buy pills from friends to avoid maybe a more dangerous route. Okay, so how do we take a history to build a patient-centered plan? You can leverage the DSM to guide it, but essentially you want to confirm the diagnosis, review his past and current patterns. Again, he said spending hundreds of dollars a week on pills, prefers the OxyContin, never taken from non-prescribed supply. So that's important that he buys this from a friend who has a legitimate prescription. He shares in terms of complications from use, that he has not had withdrawal symptoms. He has a history of diabetes, hypertension, elevated BMI, and tobacco use in terms of sort of co-occurring substance and medical and psychiatric comorbidities. He identifies complications, including that he spent all his life savings. He feels that pain is really driving this and that interferes with his life. And that he's actually been able to manage it with this plan, though the complications, the impacts are pretty significant to his finances, and he doesn't identify any oversedation or overdose history. And he is partnered and housed. And so all of these pieces, they listed, are important to just understand the basic components of evaluation and making the diagnosis. Notice that I didn't mention any labs or toxicology tests as part of that. So who is a good candidate for buprenorphine? It's someone who has a current or past diagnosis of opioid use disorder, open to taking the medication. They can keep it safe, right? They don't have any significant adverse effects of the medication or allergies. So again, this would exclude precipitated opioid withdrawal, which doesn't make them ineligible, but may make it more challenging to convince them that this is an appropriate drug for them, medicine for them. Willingness to engage with a treatment team to initiate and continue treatment. And then really the goals are varied, right? You don't have to, the goal doesn't have to be abstinence, right? But it could be reducing or abstaining from non-prescribed opioid use. A person could want to decrease the harms associated with non-prescribed use. Or it could be that, they're not currently using opioids, but they have a history of that and they're worried about return to use. So all very appropriate reasons to use buprenorphine. And then is chronic pain, a reason to use buprenorphine naloxone? So important to understand that the sublingual and long-acting injectable formulations have been approved by the FDA for addiction and not pain treatment, but they absolutely can and are used off-label. And that includes sublingual films, tablets, injectables, whereas the parenteral and transdermal formulations are approved for pain and not addiction treatment. And they cannot, underscore, be used off-label to treat addiction. And so that would be things like the Butrans patch, the Belbuca buccal film are absolutely not able to be used to treat addiction. And really, there have been good studies showing that the presence of chronic pain is not a barrier to successful treatment of opioid addiction, and treating the pain often is what helps people stabilize their opioid use disorder as well. So the basics of what you need to know before prescribing buprenorphine for anyone new in the room. So briefly, what are the major features of buprenorphine, right? It has a very long half-life of 24 to 36 hours. It is a partial agonist at the mu receptor, which is incredibly beneficial because it has a comparatively minimal respiratory suppression compared to full agonist when used as prescribed. You can see here on the graphic. Its high affinity for the mu receptor is what makes it so effective. So once it's on board, it blocks other opioids from being able to displace it, and it displaces other opioids if they are on board first. So for someone who is physically dependent on a full agonist and takes buprenorphine, that will precipitate withdrawal, as demonstrated by the arrows. And then finally, it has very slow dissociation from the mu receptor. And so that's one of the properties that we take advantage of sometimes for inductions, especially some of the off-label ones. So being able to stay on that receptor for a long time is protective. So I tried to summarize here the different FDA-approved transmucosal bupe products for opioid use disorder. You can have this slide deck, so this is just really mapping it out for you. But right, there's films, tablets, and then there's generics and brand names and dosages in buprenorphine naloxone, and also just the mono product, which doesn't have naloxone in it, and using the sort of buprenorphine, naloxone, Suboxone, and generic as a reference standard. You can see the sort of conversion for Zubsolv and versus the rest of them. And important to know, it's not a weaker medicine. It's just it's a lower milligram because it has a higher percent bioavailability in the formulation. This is what sort of the Zubsolv looks like in the Suboxone tablet. They come in white too, and then some of the Suboxone films for those who haven't seen it. And it is something that you place under your tongue, let it dissolve fully. And so we'll talk a little bit more about that. So I wanted to add some patient education because I'm not sure that everybody, I want to make sure everyone feels comfortable talking to patients about some of these pieces. So the first thing is for absorption. The recommendation is for best absorption, you shouldn't eat, drink, or smoke within 15 minutes. It impacts the ability of your mucosa to take up the medication. It is okay to moisten your mouth before taking the medicine because otherwise dry mouth makes it hard to absorb. I want to highlight this dental risk. So the FDA came out with a warning in 2022, really associating the sublingual and buccal buprenorphine products with dental caries, erosion, cavities, infections, tooth loss. And this was a pretty huge deal that came out and I think scared a lot of people and potentially, risked people not wanting to be on this medication. And so the important things to know is that there is an association, likely because of the change in acidity of the mouth when you are taking buprenorphine, especially if you're taking it 3 times a day. And so it's important to counsel on oral care, right? After the medication dissolves, the recommendation is to take a large sip of water, swish, you can swallow or spit. Don't brush your teeth actually for an hour after dosings to not disrupt the enamel. And then obviously good sort of dental care is important. And I think critical, because a lot of patients ask this, right? The dental risk should absolutely not deter buprenorphine use in the sublingual formulation. The benefits far, far outweigh the risks. And, if they really are concerns, then thankfully we have the injectables. In terms of other practical tips, nausea intolerance, just, package insert says that you need to swallow saliva once the medication dissolves. If that makes you nauseous, you can just spit it out, or patients can. And then little trick on how to open the package. So you can see that there's a little perforation that you fold at the perforation and sort of in the long way you can nicely peel off of the package. And that sometimes older folks need a little help with that too. Okay, this is my plug to think about opioid prescribing and family safety. So the FDA recommends health professionals discuss naloxone with all patients when prescribing opioid pain relievers or medicines to treat opioid use disorder. So this is really for all opioid pain medicines. It's important to remind your patients to keep meds out of reach, consider a lockbox. I always tell people to actually keep their naloxone stored with their medications. And if there's anyone in the house, kids, adults, grandparents, that it's really important to educate that the reason you're keeping it with the medication is, God forbid, someone gets into your medication and accidentally tries the medicine, right? If it's a film, whatever it is, that you can reverse an overdose. And there is absolutely no harm if someone is not dependent on an opioid to giving naloxone. Again, it can be used from infants to grandparents. So with that, I'm going to pivot to thinking about what are the best steps for prescribing buprenorphine. Again, I'll turn to a clinical resource that we made at MCSTAP, Nuts and Bolts of Prescribing. You can find it on our website at the bottom there. And so really basic, but just so everybody's on the same page, you want to check the prescription monitoring program with every prescription. You can absolutely, excuse me, absolutely have someone in your office do that as a delegate. You pick a formulation and length of prescription, you e-prescribe it because it's a Schedule 3. Here's an example for those who haven't prescribed of what it would look like. This is just an example of 2 films under the tongue for 7 days for buprenorphine naloxone, 8-2, the 2 being the naloxone component. And then again, you want to co-prescribe naloxone and really do education around medication safety. There is no evidence for optimal frequency of these visits. Sort of expert opinion is to start with weekly prescriptions unless there's concerns otherwise, and clinician nurse check-ins, and then you can sort of gradually space it to biweekly, to monthly, and then Q1 to 3 months if you have someone who's rock stable and in remission from opioid use disorder, as like sort of less frequent touch implies the patient is more stable. And again, I haven't mentioned drug testing here. I'll have a slide on it, but really the indications for drug testing is whether it would change if the results would change clinical management for you. So key federal policy updates on buprenorphine prescribing, or I'm just going to whiz through these. Some of them are old, but as hopefully everybody knows, everyone who has a DEA may prescribe buprenorphine. So the X waiver was eliminated in 2022 as a huge deal. There is a requirement for a one-time 8 hours of substance use disorder training required at your DEA, either initial application or renewal that was started in June of 2023. All you have to do is click a button saying, yep, I did my 8 hours, and save the results from that, or save the receipts from those 8 hours in case you get audited, which I've never heard of, but good to have it. The other option is if you have graduated within 5 years of a medical APP or PA school in the US that had that 8 hours of SUD curriculum, that counts, as does being board certified in addiction medicine or psychiatry. For the other thing that we think about is telehealth prescribing, and so thanks to COVID, there were flexibilities that have continued to be extended, and so just this past month, thankfully they were extended again through the end of this year, 2026. So what does that mean? That means that buprenorphine for opioid use disorder can be prescribed via audio-video telemedicine, or audio only for opioid use disorder if the patient requests it, without a prior in-person exam. And that's really important to know because we want to make sure that everyone, who is hoping to get connected around buprenorphine has access, and it shouldn't be a barrier of coming in person. Similarly, if thinking of folks who are in smaller or private practices, you can have a covering clinician prescribe buprenorphine without meeting your patient, as long as you, the primary prescriber, have had an in-person visit or an evaluated visit within the last 24 months. Really, goal is to break all the barriers down so that people can comfortably prescribe buprenorphine. And then finally, my plug on toxicology testing. There are no federal requirements for toxicology testing. We have an American Society of Addiction Medicine consensus document that provides a general standard of care for recommendations, but really this is an evolving space. We used to sort of very heavily test people for substances, but really it's important to ask the question of, is this going to change management, and do I need these results before I make a prescription? And really, testing should not delay the initiation of treatment. You can always prescribe, get someone's toxicology test, and then pivot or evolve your treatment plan if needed. When is toxicology potentially valuable? Again, confirming that the patient is taking the medication that you are prescribing or medications, potentially to recognize any potential interactions with other medicines, and then helpful to know and for your patient to really have a conversation about what they may be exposed to if they're using non-prescribed medications. So for this patient, he was reporting that he was not using any illicit substances, and they were all prescribed. We don't know that. We got a toxicology test, but we ended up giving him instructions for the traditional induction, and this has been around since 2013, which you guys can find, and I'm happy to share. But essentially, right, you have to be in mild to moderate withdrawal before you take buprenorphine. The recommendations are that you have at least 3 physical symptoms before initiating the medicine. And then really the benefits of in-office inductions are pretty limited. So if someone was terrified of precipitating or otherwise really needed assistance, that would be one thing. But the vast majority of inductions are done at home and have been proven to be safe, effective, patient-centered. And then, when in doubt, really listen to your patient, because many of them have taken buprenorphine before and really can guide you with their experience. So essentially that, the sort of basics are that once you are in sufficient withdrawal with at least 3 symptoms in this traditional induction, and we'll be talking about other ones, you would take 4 milligrams of buprenorphine. That would peak around an hour. So as long as you're, feeling okay, or still feeling unwell but not worse, then you would take a second dose of that and continue essentially until you feel better. In this example, they say don't go above 12 milligrams. That has shifted, and now we get people to higher doses on that first day. And then they would take either a split dose or the whole dose of the medicine that second day. Okay, so just to summarize for this patient, you made the diagnosis, you checked the MCSTAP, you provided education, and you confidently prescribed a week of buprenorphine naloxone at 16 milligrams a day in divided doses with written instructions on how to take the medicine, and you co-prescribed naloxone. You did get a toxicology test to better understand the patient's possible exposure in case there was he was using from an adulterated supply. And then I think this is the important point with, I think it's very appropriate to send a week of medication for most patients who you start, but I would actually check in with them sooner than that if they're starting. So consider a virtual follow-up with you or a nursing, team member within 3 days to really ensure that they were able to get on the medication, to review their dosing. And really, I encourage people, if 16 isn't enough, then absolutely go to 24 milligrams over those first couple of days, and then we'll check in, and I can give you an earlier refill if that's the dose that you end up feeling more comfortable on. Okay, so I'm gonna keep going and now shift to really thinking about inductions and the illicit supply. So this is our case 2. She's a 38-year-old in your office for a new patient visit. Per the chart was seen in the emergency department a couple weeks ago for opioid overdose requiring naloxone. Left the emergency room with what we call a to-go kit of 6 films of buprenorphine, and has since picked up fentanyl again. And you just came from this lecture and heard about the substantial mortality benefit of medications for opioid use disorder, and decide to offer buprenorphine as this life-saving intervention. So what do I do? What are the first steps of intervention? And then how do fentanyl and high potency synthetic opioids and other contaminants possibly impact induction? And so again, just to recap, what are the first steps in evaluation? You want to confirm the diagnosis, really understand the use pattern, and assess the patient's prior experience of buprenorphine and make a patient-centered plan. So again, here you didn't hear labs and even like a full physical exam are really secondary. It may be helpful to get a toxicology test, but it wouldn't change the initial management of getting someone onto the medication. Not essential at the first visit are thinking about testing for HIV, Hep C, complications, other infectious complications, but it is a good idea to make that standard practice. And so would not withhold medicine, but really encourage patients to think about getting tested for these pieces. And again, check the PDMP. Okay. So has there been any fentanyl or high potency opioid exposure, and how can it impact induction? So just to recap, fentanyl and its analogs have a really rapid onset of crossing. They have a rapid onset, they cross the blood-brain barrier, They are 50 to 100 times more potent than morphine. Again, that doesn't even count some of the analogs, which are even more potent. It is a highly lipophilic molecule that's rapidly sequestered in the fat. And what that means is that actually patients who are regularly using it, it both stores in the fat and you can actually see a delayed renal clearance. So one study put an average of up to 2 weeks or even 4 weeks. And again, that's even higher or longer, sorry, I should say, for the films when someone is pregnant. And so that's really important because, again, as you're thinking, if there is a toxicology test, you know, you may see ongoing trickle of fentanyl come out. And what this really impacts is an unpredictable withdrawal course where there is a patients who may be using multiple times a day to really keep up with the withdrawal. And yet there's this long tail that we see that makes it hard to get on buprenorphine. In Massachusetts, I would safe to assume that for the last 5+7 years, right? But that if someone is using non-prescribed opioids, that assume it's fentanyl, unless they're coming from a prescribed full agonist. So what do we care about? We don't want to make patients sick. We want them to be able to tolerate the induction so that they use they use buprenorphine or methadone, right, as sort of the only two first-line treatments we have for opioid use disorder. So we don't want to turn them off from it with a really terrible experience, which is precipitated opioid withdrawal. And that is the rapid onset of objective signs and symptoms of an opioid withdrawal syndrome that hits 30 to 60 minutes after the initial administration of sublingual buprenorphine. And that's because that's, you know, how quickly the buprenorphine gets absorbed and peaks in the person's serum. So thinking of the clinical opioid withdrawal scale, or COWS, you're looking for a change in COWS within that 30 to 60 minutes by 5 points to be sort of formally considered precipitated opioid withdrawal, right? Pupillary dilation, piloerection, restlessness, vomiting, diarrhea, agitation. The concern, again, is that it's absolutely miserable for patients. It is incredibly stressful for the medical team to watch someone so uncomfortable. It often leads to a return to use and avoidance of buprenorphine in the future, and then contributes to medical trauma. And, you know, the real challenge is that patients, you know, may describe that they've caused precipitated withdrawal in the past, and, you know, it really, no one is sort of sitting there scoring, right? And so there is variability in the presentation and a broad differential. And so it's important to really make sure that you're thinking more broadly when this happens or when someone's describing it, right? And so what is the differential in terms of seeing someone in this state? And the first one is actually just undertreated withdrawal, right? Is this someone who, you know, they just didn't get enough buprenorphine in them sufficiently to match the sort of level of opioid debt that they're experiencing naturally from opioids leaving, right? And so that's one. Is there another substance intoxication or withdrawal that's happening, right? You can certainly get pupillary changes with like stimulant, methamphetamine intoxication, thinking about alcohol, benzos, you know, xylazine or others, that they may be either intoxicated or withdrawing from, and then medical complications that you would need to think about. So just keep saying, you know, I would keep a broad differential if this happens. And so what about fentanyl and the emerging illicit drug supply that it is making this even more complicated than it was, you know, a couple of years ago? And so I'm going to go over some trends in the illicit drug supply in Massachusetts. So we've got some great local data because it really does complicate inductions and really adds to the importance of getting folks who have active use disorder onto medication for opioid use disorder. So if you don't already know about Street Check, it is a phenomenal website that is based at Brandeis, where really it is a real-time checking of patients' drugs in partnership with community drug checking programs to really understand what's going on and what are we seeing, you know, in real time on the street. And Street Check is a website that anyone can check out. info@streetcheck.org. Data is what I'm going to sort of walk you through briefly just to give you an example of emergent drugs. I checked it, I think, this weekend. So these are in real time. And this is the QR code if you wanted to get to the website another way. But essentially, in Massachusetts, right, we are seeing potent synthetic opioids, right? So fentanyl analogs, nitazines, and tianepeptine, which are all responsive. They're all synthetic opioids. So they do respond to naloxone, and they are treated with getting folks on medication for opioid use disorder. But we're also seeing a lot of other junk in there, right? So we're seeing xylazine and medetomidine, which I'll talk a little bit more about, which are both veterinary alpha-2 receptor agonists. Medetomidine is actually xylazine, we've heard of, I think, for a couple of years now. It's been in our drug supply for the last few years and causes awful, really awful wounds. But medetomidine is a new kid on the block, and it's actually 200 to 300 times more potent than xylazine. So I'll, on the next slide, tell you a little bit more about that. And then BTMPS, which is an industrial chemical used as a UV protectant in plastics and adhesives, is also in our drug supply, right? And so really valuable to understand, to let people know what's in the drug supply. And you can see up top the percentages in the samples collected over the last 12 months. And so Street Check then actually makes it relevant and helpful for, they put out info to let people know what's going on in the drug supply. So this was information they put out when we were seeing a really bump in the stimulants in our drug supply. So responding to crack and methamphetamine, and they give information about smoking kits, thinking about unexpected cuts. There's again xylazine since 2022 and some info on that came out in 2024. The nitazines trend came out and was shared. And then there's the most recent update again from June of last year was on medetomidine, right? And so it was in Philly in 2024, and then since summer 2024, it's been in Massachusetts. By June of this year, last year, it's been in every county in the state, right? And so what do you look for? It's people have really serious and severe withdrawal. So it may cause the intoxication effect, right? May cause heavy sleepiness, dry mouth, slow breathing, low heart rate and blood pressure, muscle twitches, and even hallucinations, right? It is, again, stronger and lasts longer than xylazine, which is also really complicated presentations of intoxication, of overdose. And some quotes from sort of what patients were sharing in terms of what it felt like to have medetomidine in their system. It is making it certainly harder for folks to be able to tolerate withdrawal, to get onto buprenorphine. And while it is not responsive to naloxone, you should absolutely be using naloxone in these folks for the opioid component. And so with all those adulterants, with fentanyl and all of its analogs, let's turn to thinking about buprenorphine inductions for our last 20 minutes. This is old at this point, a couple years old, but a really powerful commentary to read by Kim Sue and others. A plea from people who use drugs to clinicians. We need new ways to initiate buprenorphine in the fentanyl era. And then more recently, just last month in JAMA Network Open was a review, or a survey done for folks who are treating with buprenorphine providers, to ask how frequently are providers experiencing problems getting patients onto buprenorphine, and has it changed clinical practice? And just sort of the summary statement here, but interesting to read. 72% of patients studied, or of clinicians surveyed, reported encountering problems initiating buprenorphine treatment. And 2/3 have had to change their standard induction protocols. And this is heavily skewed to folks who have higher panels of buprenorphine are really finding the need to change their standard induction protocols. And so again, we're seeing it on the ground, but it's sort of nice to know that this is happening, that, we're all trying to figure this out together. And so what are the emerging strategies for induction? I share the traditional induction, which unless someone is on really a full agonist prescribed medication, is not the direction that clinically we've been able to use in the last couple of years, simply because of, as everything I just said, that fentanyl is a different beast with a very quick on and off and then a very long tail. So it's just a very tricky, the illicit fentanyl specifically, right, is a very tricky thing to transition to buprenorphine. So starting with high dose buprenorphine inductions, the concept here from the traditional is that you actually, instead of sort of slowly over 2 to 3 days, get someone on a stable dose. This is actually shrinking that down to a rapid escalation of dosing over hours. And really the idea is that we want to not have people sit in this sort of uncomfortable, undertreated state for too long. And we want to get people fully, maximized with the agonist properties of buprenorphine onto their receptors to protect against overdose, hopefully get them more comfortable sooner. The critical piece to know about high dose buprenorphine induction is you absolutely have to be in withdrawal. This is not giving a high dose of buprenorphine for someone who is, not in withdrawal, as that would throw them into precipitated opioid withdrawal. The challenge with high dose bup inductions are that really there's no consensus on sort of the level of withdrawal, the timing, the dosage to give, and really the take-home message is go big or go home, sort of. If you use lower doses of buprenorphine, 4 milligrams, 8 milligrams, 2 milligrams, you're gonna get the patient stuck in withdrawal, and it's gonna be unsuccessful. And so if someone's in withdrawal, you are going to really saturate aggressively their receptors with buprenorphine and use comfort meds as needed. And so what does that mean? That means actually getting 24 milligrams or more in those first couple of doses into them, rather than, again, the 4 to 8 milligrams. And in case reports and emergency rooms and others, folks have gone up to even like 64 milligrams sort of over the hours. And that doesn't mean they stay on that actually just means sort of to get them over the hump, and then usually go to the 16 to 24 milligram dosing after. In terms of what evidence there are, it's really limited to case reports and case series, and mostly within hospitals and emergency rooms. There is another great plug for a website, the Bridge to Treatment. California Bridge has wonderful provider and patient-centered, patient-facing handouts. And so this is the sample protocol for a sort of a rapid a buprenorphine self-start, which, in this example, they have the patient take 2 of the 8 milligram tablets or strips under the tongue at the same time and repeat that in an hour to get up to a sufficient dose. So that would be like, getting them to 32, for example. They do put a nice warning, which is important if you think about our first patient, right? So if you have a light habit, right? So this doesn't apply to someone who is, coming from either a very light habit or prescribed full agonists. And then, again, if you have a very heavy habit, a significant fentanyl use, consider being more on the aggressive side. Okay. So the next sort of bucket of induction protocols is called low dose buprenorphine with opioid continuation. It used to, be called, there's a Bernese method. There's a crossover. Microdosing was another term used in the past, but sort of the most important idea is that you are simultaneously continuing the full agonist while you're sneaking buprenorphine in very teeny tiny doses up every day, and taking advantage of the fact that of those properties that we talked about at the beginning, that has a very long half-life. And so the buprenorphine slowly builds up. Initially, the doses are less than 1 milligram. And so this is just sort of one of the pictures from the web about, if you're giving an 8 milligram film, how small the patient has to cut it up to get to the 0.5. And so usually, we're using 2 mg films, for example, for this, if we're in the outpatient. Inpatient, they have a lot more options like IV, buprenorphine, buccal films, the patches, etc. In terms of evidence for the outpatient space, there are a growing number, a ton of case series and protocols, but there haven't been any high quality studies or head-to-head. There are, in general, sort of similar protocols to the one that I put here, in terms of there's a rapid and a standard sort of 7-day protocol, and usually you're adjusting those based on how the patient is feeling. So, if they take 0.5 in the morning and then 0.5 in the evening and do fine, great, you continue on. If actually, they take go to 1 milligram and they've started to feel some withdrawal an hour later, then we either say continue on that dose, back off and go to 0.5s, or allow the process to catch up with you, and don't rush it. The challenge is that the protocol is very hard to. The protocols are very hard to follow. Someone mind muting. They're very hard to follow if you think about sort of the need to sort of keep adjusting this. So sometimes groups will use pill packs or bubble packs to try to make this easier. Another trick is to not actually prescribe only use 2 mg films at first, and then once the patient's on a high enough dose, then you can switch to the 8 mg films. But we've gotten in trouble where if you give someone 2 doses and they make a mistake and take 1/4 of the 8, right, they can go into withdrawal. So just want to be careful with sort of really explicit patient instructions, and then close follow-up. And the other challenge that has come up, and some of these newer studies really highlight that, are that you have to really let people know that it's not a withdrawal-free experience, right? And so we are trying to avoid precipitated withdrawal to get people onto buprenorphine, but there is going to be some mild to moderate withdrawal based on the sort of looking at the case series that have been collected. And so sometimes anticipating that, letting the patient know, providing comfort meds will help sort of reduce some of the anxiety and hopefully allow people to be successful. And then precipitated opioid withdrawal isn't zero. In some of the case studies, it really was for folks who didn't follow the directions correctly, right? So they maybe took, again, a medication too early, or a dose that was too big too early. And so again, warning patients about that. And then how successful is it? It's not great, right? And so one of the retrospective case series in SWEN that came out in 2025 actually found that they were successful 34% of the time in the real world outpatient. And so I think for a lot of reasons we still use this, and I think it's not ideal, right? It's something that it can take days to weeks, right, when someone is unfortunately still having to use their full agonist and to do this. And so it's not without risk, but it is certainly more effective in this climate than the traditional induction. And so this just summarizes the sort of induction options to wrap your head around. So we have the standard, which you heard at the beginning of the talk. There's the low dose the low dose without crossover, which is inching up buprenorphine throughout the day without full agonist. And then there's a high dose where, again, no agonist and you're just ramping up. So these are sort of the 3 inductions where there's no crossover. And then there's the crossover, which is what we just described, where you continue on your full agonist. And so I just wanted to sort of map that out in case people think about, depending on how you sort of frame this in your brain. And then what about injectables, right? So these are really game-changing, I think, for a lot of folks. The 2 we have on the market are Sublocade and Brixadi, depicted up here, right? They provide a steady state of continuous buprenorphine from the sub-Q depot. The benefits are no need for daily dosing, which is great for those who either can't tolerate the sublingual, they can't keep their meds safe, maybe homeless or other sort of unsafely housed. It eliminates the need for medication storage, which also can be a safety issue at home, right? In terms of thinking of kids or others in the house. And so you don't have to worry about that. And it really, I think the benefit in the fentanyl area is it gives you a higher and more consistent serum level than the current sort of dosing that we have. And a couple of caveats, the steady state is not reached, excuse me, until you get to about 4 to 6 injections. And so it's important to let patients know that they may feel fantastic after the first injection, but actually for folks who are coming off fentanyl or very high use, it may take a couple of months for them to really feel totally normal and not need sublingual supplementation earlier. Again, thinking about sort of in the formulations, you might need to continue the loading dose beyond the first couple months. It's nice because now we have weekly and monthly versions, which allow for more flexibility. There's even some recent changes where we can give sort of the second loading dose after a week of the first, really to try to get people to steady state sooner. And then the next thing I'm going to talk about is just the emergent use in inductions and rapid starts. And so there's so much to talk about here, but I'm just going to focus on sort of one trial. This is the sort of in the sense of in the setting of the direct to inject buprenorphine initiation that is gaining a lot of interest and use. It's the major publication was the ED Innovation trial that Gail D'Onofrio and others published on, and that it was part of a multi-site study looking at 28 emergency departments really across the US of all types, so academic, rural, small, large, and of the 800 patients that were randomized to the extended release bup arm over the years, the protocol was that once their cows was 4 or above, they were given a weekly injection of the XR buprenorphine at the 24 milligram dose, and then observed for 2 hours and discharged with follow-up in 7 days. And they, interestingly found very, very low rates of precipitated opioid withdrawal by the time of the 2-hour ED discharge, and that was in folks using fentanyl. And so this really, is a potential game changer, and I think it really has been, with a couple of caveats. Number one is that you absolutely really, if you're going to do this method, need to make sure that the patient has objective signs of opioid withdrawal that are not explained by anxiety, that are not explained, subjectively or by another substance. So true mild, but objective withdrawal. And I would caution that, the clinical experience that we've seen sort of outside of the emergency department has been that these low rates of precipitated opioid withdrawal haven't necessarily been reproduced. And so it is, important to follow the protocol if you're going to use it, and also think about sort of the set and setting that you're in. And I just want to explain in this graphic why this works, which is pretty elegant. In the gray line, you can see sublingual buprenorphine has a very high, quick onset and peak, right? So you get this rapid peak of, within an hour, 30 minutes to an hour, to a pretty high serum level. And the injectables, and especially the weekly injectable, actually has a nice, slow, gradual onset. And so it actually doesn't really reach sort of peak until 24 hours, but really the 8 to 10 hour mark is where we see sort of it reach roughly the, the higher dosing, the higher serum level. And the idea is that actually gives time for the sort of natural withdrawal from the full agonist to continue while the bup is ramping up. And so pretty elegant. And so I showed you all of those. So like my summary for what makes a buprenorphine induction successful is really number one, patient preference. So let your patient lead. Do they, is this one who, needs to get on buprenorphine tomorrow, or are they really not ready to stop and they want to do it gradually? Do they have access to safe supply? Sort of how you're thinking of the risk benefit of continuing, non-prescribed full agonist. Timing, right? Are they, again, like I said, do they need to be offered tomorrow? Are they willing to go to a higher level of care? Do they have supportive family? Do they just get kicked out of their OTP, their methadone clinic? In terms of location, again, I mentioned that most are done outpatient or in induction centers, ATSs, bridge clinics, sort of rarely sitting in an office over 8 to 10 hours, and that you really have to know your clinic resources, right? So if you have the bandwidth in your clinic for a high touch protocol, wonderful. If not, that's, I think, one of the great purposes of bridge clinics, to be able to sort of stabilize someone and then return them to you. And then finally, like you have to know what agonist the person is using, right? Is it methadone? Is it fentanyl, prescribed, et cetera, and what their habit looks like. Okay. And so in the last few minutes, I'm just gonna sort of continue to this case and what it looks like to continue buprenorphine in the era of fentanyl. So again, this is a 38-year-old. She's now status post a bup home induction and has been seeing you weekly for a visit for the last couple of months, taking 16 milligrams or 8 milligrams of bup twice a day. And the toxicology test is persistently positive for fentanyl. And so really, you want to think about, is treatment working for the patient? How can I optimize the medication to keep them safer? So this is an old but a wonderful study that really demonstrates that ongoing use during early treatment is expected. And so what you see here is that, the sort of the natural course of the disease with buprenorphine and methadone treatment, which are their two bottom lines, is that this gradual extinguishment of illicit use. And that, that makes sense. This isn't a quick fix. The other important thing to understand is that actually there's a growing body of evidence supporting what we're seeing clinically, which is that higher doses of buprenorphine are needed than prior to the fentanyl era. And so this is just one study which really showed that folks who were on 24 milligrams of buprenorphine versus 16 had engaged in treatment longer. So less, the lower dose had a higher risk of treatment disengagement. And so important to think about, again, is my patient on a sufficient dose? And then there were some really important articles that came out questioning our outdated buprenorphine dosing limits, right? And so prior authorizations required, for example, to go above 24 milligrams. And in this figure, what you can see is sort of from this paper by Grande that the plasma, our understanding of sort of what serum level of buprenorphine is needed to reduce cravings, block euphoric effects, and have people just feel normal, has actually shifted sort of with the era of fentanyl. And so it used to be that as long as you're above 1 nanogram per ml, we thought that was sufficient. And now in the sort of 2, now we're really thinking it's probably 3 to in these studies, 3 to even 5 milligrams to suppress drug likability and prevent overdose or respiratory suppression. And so there was sort of a plea to say, that these FDA guidance for 16 milligrams is really outdated, and a dose range is much more appropriate to be 24, a minimum of 24 milligrams. And that actually some people need higher doses than that, and higher doses actually reduce harm and keep more patients safe. And so just thinking about the dosing that you're using for your patients, and if they're still using fentanyl, right, you likely need to go up. Okay, so that is it. I'm just leaving you with some resources about, here's a checklist on integrating harm reduction to the outpatient space. If you don't know of this wonderful program called SafeSpot, it's a hotline that your patients can call who are using, so they're not using alone, and they can basically stay on the phone with someone who understands what they're going through to prevent an overdose alone. And then I'm going to leave it here. So that was a whirlwind. We're going to pick this up again on February 23rd at noon. What I would love is if there are questions that you have, things I didn't, go over, topics that you want covered, let us know, and we'll build those in. A small plug here on my other role at the Massachusetts Study of Addiction Medicine is that we'd love to hear if you are having trouble with dose limits, monoproduct coverage, complex pain management. fill out this little survey, which will just allow us to sort of keep tabs and help advocate at a state level. So I'm going to stop sharing. I think I'm on time. Oh, at the buzzer. So thank you all, and yep, keep entering your questions in the chat or send us via email. And I look forward to connecting with those who can in 2 weeks to be able to sort of dive into more cases and more interaction. Thank you, thank you. For transdermal patch and parental, do those restrictions apply to hospital? Yeah, so no, in the hospital, you're able to use all formulations of buprenorphine, and it really only applies to outpatient where we're restricted by that prescribing mandate. Okay.
Thank you, Jess, and we really appreciate it, and we'll see you in 2 weeks.